Parkinson's disease we've most often thought about as a motor disorder, with the characteristic clinical motor features of bradykinesia, rigidity, and tremor. But over the past decade or two, it's really become apparent that non-motor symptoms are very frequent and actually sometimes predominate, especially affecting patients' daily activities and quality of life. One of these non-motor features, PD psychosis, seems to be quite common, affecting maybe 50% or more of our patients over the decades-long course of Parkinson's disease. PD psychosis refers to patients who have Parkinson's disease already diagnosed, who then develop hallucinations and or delusions that begin to affect their daily lives. Our treatment options, though, are limited for treating our patients who have PD psychosis, and the reason for this is because this psychosis is different than psychoses of other disorders. It occurs in a brain depleted of dopamine, and when we try to address it, we typically don't increase the dopamine medicines and stop treating their motor symptoms optimally many times, or we use medications, off-label antipsychotics, that can block dopamine D2 postsynaptic receptors and worsen motor Parkinson's. We do have two atypical antipsychotics that we can use off-label because they don't worsen motor symptoms, but all other ones do worsen motor symptoms and cannot be used in PD patients except for quetiapine and clozapine. Quetiapine, though, has lacked efficacy in 4 studies that have been done and has sedation as a major limiting factor. And of course, clozapine is rarely used. Less than 2% of patients with PD psychosis are treated with clozapine in the US, mainly because of the burden it places with regular blood tests due to the risk of agranulocytosis on clinicians and on patients themselves. Recently, the FDA had an advisory committee that voted 12-2 in favor of approval of a new medication for PD psychosis called Nuplazid, and hopefully it will be approved this year to treat the symptoms of PD psychosis. Nuplazid has a completely novel mechanism. That is, it doesn't block dopamine receptors. It's not a neuroleptic. Instead, it blocks 5-HT2A serotonin receptors. It's an inverse agonist at the 2A receptor. And in pivotal studies, it was able to reduce both the frequency and the severity of psychosis symptoms of delusions and hallucinations. And the publication was in Lancet a year or two ago. And this study will probably lead to the approval of this drug in the next several weeks. It seemed to be very well tolerated as well. And ongoing studies are looking at its durability and its use in the PD population. It's really a disorder, PD psychosis, as we're learning, that doesn't reflect too much dopamine per se, but really is part of the neurodegenerative process with serotonergic dysfunction, and then things trigger the brain to have psychosis symptoms, whether it's a urinary tract infection, concomitant anticholinergic medications, or too much dopamine medicines, but it's on top of a degenerating brain that has serotonergic dysfunction. And that's why using a new drug like Nuplazid that can block 5-HT2A receptors has been able to reduce psychosis symptoms. When psychosis symptoms arise in our patients with Parkinson's disease, oftentimes they're mild, and some people have called them benign. They might be illusions where patients falsely interpret stimuli that they see, and they may see a person in the trees, or they may feel a sense of passage of someone behind them. But over time, invariably, patients lose insight, and these become more frequent and more severe and more troublesome in affecting daily activities. It's very concerning sometimes when patients see things that aren't there or feel things that aren't true. But it may not even be so clear because patients are reticent many times to explain it. There's a stigma associated still with psychosis symptoms. And patients may not even recognize that it's the neurologist that they need to tell these symptoms to. They may not even connect it to Parkinson's disease. So we think it's very important that patients and their caregivers recognize from the earliest diagnostic stages that non-motor symptoms occur as well as motor, and these can occur: memory problems, depression symptoms, psychosis symptoms, constipation, other GI issues, bladder issues, and all these non-motor symptoms. And that this way they'll know when they begin to see or feel things that aren't true to let their physician know. And we have to then ask questions to see the impact on daily activities. It may seem comforting to see a little dog that appears in the morning by the bed. But if that dog begins to growl or bark or jump on the bed, or people stay in bed because they're afraid the dog might bite, it becomes problematic. It can get worse, where some of our patients have put dog food around the house, creating a fall risk of tripping over it, or barricaded the doors when they felt the dog brought other dogs. And now there's a pack of dogs waiting for them to get out of bed and to get them. So it's really important to recognize that even when it's very early and mild, these will invariably progress and become more severe. Caregivers are also part of this process because caregivers go through the journey of Parkinson's disease with our patients for a decade or more, helping with medications and mobility, setting up as balance and walking becomes affected, wheelchairs at the airport, and now suddenly a patient with psychosis and Parkinson's is different because the dopamine medicines are no longer increased as they need to be and mobility is worse. And sometimes the delusions that occur are usually directed specifically at the caregiver. So our caregivers who have been so much part of this journey now are being accused of marital infidelity even after 50 years of marriage, or being told that they're stealing money or poisoning food or not being around or leaving. So this burden on caregivers has been significant, and indeed psychosis is one of the major factors of increasing caregiver burden in our patients with Parkinson's disease and their caregivers and family. And in the Nuplazid trials, we were able to measure caregiver burden using caregiver burden scales that have been used and validated, and saw an improvement that was significant in caregivers when the patient was treated with Nuplazid to reduce delusions and hallucinations. So it's not just the patient, it's also their caregivers and family that are so impacted by this disorder, and that who we think that the availability of Nuplazid will really help all of them. PD psychosis also is important because not only does it cause these symptoms that trouble our patients and interfere with our optimal treatment of Parkinson's disease with dopamine medicines and affects their caregivers and families, but it's a major reason why our patients with Parkinson's disease enter a nursing facility. And when they enter a nursing facility, it's usually permanent. It's also an increased mortality in patients who develop psychosis. And perhaps most importantly, almost a quarter of all hospitalizations of a Parkinson's disease patient are due to psychosis. And once patients get into a hospital, it's very difficult for patients to go home so rapidly because the medications are adjusted wrong, it may not be on formulary, they're kept at bed rest, they get deconditioned, blood pressure problems emerge. So it's so important that we're able to recognize these symptoms early and not wait until they become so severe or frequent that patients have to be admitted to a hospital and things go awry and they go into a nursing facility. We've often thought about when PD psychosis might occur during the course of Parkinson's disease, and it turns out that patients can develop psychosis early on in the disease or later. It can happen without dementia, or it can happen in people who are developing a dementia. There is a higher risk of developing psychosis symptoms in Parkinson's disease if the dementia is present, and there's a higher risk of developing a dementia if psychosis has occurred. But PD psychosis can clearly occur and often occurs in patients who do not have dementia. So we have to be very vigilant of asking these symptoms in all of our patients throughout the entire course of Parkinson's disease.